Every 40 seconds, somewhere on this planet, a brain issues its clearest possible warning. Not the stroke itself, the warning that arrives before it. A transient ischemic attack, what most people call a mini-stroke, lasts a few minutes, sometimes less than one, and then vanishes completely. The arm works again, the vision clears, the words come back. And because everything returned to normal, most people do exactly what you would expect them to do, nothing. That decision feels reasonable. It feels proportionate. The part nobody tells you clearly enough is that it is the single most dangerous mistake a person can make in the hours after that warning. The resolution of symptoms is not the resolution of the threat. Those are two completely different events, and confusing them is what empties the 72-hour window before it has been used. Research shows that the risk of a full ischemic stroke is highest in the 24 hours immediately following a transient ischemic attack. Not in the weeks after, not after a second warning arrives. In the first day, the probability remains significantly elevated through hour 72. After that, the acute peak has passed. This is not a rough estimate. It is a documented risk curve with a specific shape, steep, front-loaded, and entirely indifferent to whether your symptoms resolved 10 minutes ago. Most people, when they hear that, assume it applies to someone else, someone whose episode was more dramatic, someone whose symptoms lasted longer. You would probably make the same assumption. Here is why that assumption is wrong. A transient ischemic attack and a full ischemic stroke share the same underlying mechanism. In both cases, blood flow to a region of the brain is interrupted. The difference is duration. In a TIA, the interruption is brief, a few seconds, a few minutes, and blood flow resumes. In a full ischemic stroke, the blockage holds. Brain cells in the affected zone begin dying in roughly 4 to 6 minutes, and those cells do not come back. What causes the interruption is almost always one of two things. A fragment of plaque or clot breaks away from the inner wall of a narrowed artery. Most often, the carotid artery in the neck travels upward and briefly lodges in a smaller vessel before drifting free. Or a spasm tightens an already narrowed vessel for a short time and then relaxes. In both cases, the brain loses blood supply for a moment and then recovers. In both cases, the underlying artery is still damaged, still narrowed, and still capable of generating another blockage, a longer one, at any point in the next 72 hours. The clot drifted, the spasm relaxed, the plaque is still there. Think of it this way. A smoke alarm goes off in your house. You check the kitchen, find nothing visibly burning, and the alarm stops by itself. You go back to what you were doing. The alarm stopping does not mean the wiring is safe. It means the smoke cleared for now. The source has not been found, has not been repaired, and is still inside the wall. A transient ischemic attack is that alarm. The fact that it stopped is not reassuring. It is information about timing. Most people who waste the 72-hour window do so for one of three reasons. The symptoms self-resolved and felt too minor to justify an emergency room visit. You talked yourself out of taking it seriously because the strange episode was already gone. You went to an emergency room and were sent home without brain imaging because the symptoms had cleared by the time you arrived and the neurological exam came back normal. Or you had no concrete action plan, no knowledge of what to ask for, who to speak to, or what the next 72 hours actually required. All three of those situations are understandable. None of them are safe. The emergency room failure pattern for transient ischemic attacks is well documented in clinical practice. A patient arrives describing symptoms that have already resolved. A brief neurological exam returns normal. The patient is discharged with instructions to follow up with their regular physician. No carotid ultrasound, no extended cardiac monitoring, no imaging that would identify a vessel narrowed beyond the point of hemodynamic significance. The patient goes home relieved. The vessel is unchanged. Being told that everything looks fine is a sentence. It is not a diagnosis, and it is not the same as being cleared. The reason the 72-hour window matters is not only about risk, it is about what becomes possible inside it. During those hours, the exact mechanism driving the transient ischemic attack can be identified. A carotid duplex ultrasound can show whether a vessel is narrowed to the point where blood flow is already critically impaired. A blood test can reveal whether blood sugar has been quietly damaging the inner lining of your arteries for years without a formal diagnosis. A 24-hour cardiac recording can catch a dangerous rhythm that a 10-second clinic ECG would miss completely. And if a correctable cause is found, intervention can begin before permanent damage occurs. That is the whole logic of the window. Not panic. A specific, time-sensitive period during which the right questions asked to the right people with the right tests requested by name can change what happens next. You are inside that window right now, or someone you know is. What happens in the next 72 hours is still a variable. The sections that follow walk through each step, from the moment symptoms appear, through the hospital conversation, through the 24 to 72-hour follow-up period, and into the long-term steps that lower the probability of this happening again. None of it requires medical training. All of it requires knowing exactly what to ask. The first 60 minutes after a transient ischemic attack are the most disorienting. Symptoms may have already resolved by the time you register what happened. You feel normal. You feel embarrassed about making a fuss. You wonder whether you imagined it. You would probably do what most people do: sit down, drink some water, and wait to see if it happens again. Here is why that instinct, however reasonable it feels, is the wrong response. Lie down, not in a recliner, not propped against pillows. Flat, on your back, with your legs elevated slightly above the level of your chest. This position supports blood flow to the brain, reduces the workload on the heart, and avoids the drop in cerebral perfusion that can occur when someone who has just had a vascular event sits bolt upright or stands. Keep your head neutral, not bent sharply forward, not tilted back. Both extremes can compress the carotid and vertebral arteries running through the neck, and in a vessel that is already narrowed, that compression is not trivial. Do not take a hot shower. Sudden vasodilation from heat in an already unstable circulation can cause a rapid drop in blood pressure and make things significantly worse. Do not drink alcohol. Do not smoke. Nicotine causes immediate vasoconstriction followed by rebound dilation, and the chemicals in cigarette smoke make blood thicker and stickier within minutes of inhalation. These are not long-term lifestyle recommendations for later consideration. They are instructions for the next several hours. Do not take aspirin or any other blood-thinning medication on your own. Most people assume aspirin is the right move. The instinct makes sense. Aspirin thins the blood. Blood thinners help when a vessel is blocked, and a TIA involves a blocked vessel. But there are two main types of stroke: ischemic, where a vessel is blocked; hemorrhagic, where a vessel is bleeding. No person, no matter how medically informed, can determine which type is occurring without brain imaging. Giving a blood thinner to someone having a hemorrhagic event accelerates the bleeding. It can be fatal. The only way to distinguish the two reliably is a CT scan. You would probably assume ischemic because that is the more common type, and in most cases you would be right. But most cases is not a number you want to gamble with when the alternative is a scan that takes minutes. Until that scan exists, no blood-thinning medication should be taken. Do not drive yourself to the hospital. If you experience even a brief recurrence of symptoms at highway speed, a few seconds of vision loss, a moment of arm weakness, a word that will not come, the consequences extend well beyond you. Call emergency services or have someone drive you, and the destination matters. Stroke guidelines consistently point towards certified stroke centers rather than general emergency rooms. A certified stroke center has neurologists available, has dedicated imaging protocols for vascular events, and moves from arrival to diagnosis faster than a general facility. In clinical practice, the difference in time to imaging between a certified stroke center and a general emergency room can be measured in hours. Inside a 72-hour window where risk is front-loaded, those hours are not a minor detail. The second step begins the moment you arrive, and it is a conversation skill that most people have never needed before and have no reason to have practiced. Emergency departments triage by current acuity. A patient who arrives describing symptoms that have already resolved, who is walking and speaking normally, who shows shows no visible neurological deficit on a brief exam will not automatically be prioritized for a neurologist. You would probably assume the system would catch it. Here is what the records actually show. TA patients are routinely evaluated by general physicians, discharged without brain imaging, and sent home with instructions to follow up later. The prioritization toward a neurologist has to be requested clearly and by name. The phrase that moves things fastest in clinical practice is not, "I think I had a mini stroke." It is, "I had a transient ischemic attack. I need a neurologist, not a general physician, and I need a CT with contrast and a carotid duplex ultrasound." Those are specific requests. Specific requests are harder to route around than general complaints. If you are accompanying the patient rather than being the patient, your role is to repeat those exact words if the patient cannot. Before leaving for the hospital, write down 4 things: the time symptoms started, how long they lasted, which side of the body was affected, whether speech was involved, either producing words or understanding them. This written log is not a formality. It is clinical information that changes the differential diagnosis, affects which imaging is ordered, and determines which specialist needs to be involved. Neurologists evaluating a possible TA will ask exactly these questions. Having the answers written on paper with times means the information is accurate and does not depend on memory under stress. Ask specifically for a carotid duplex ultrasound, not a basic ultrasound which shows only the structure of the artery wall. A duplex ultrasound which shows both the anatomy and how blood is moving through the vessel, including whether flow becomes turbulent and accelerated at a narrowed segment. That turbulence is the signature of a vessel narrowed enough to impair blood flow meaningfully. A structural image alone cannot provide that information. The third step covers the 24 to 72 hours after initial evaluation, and it begins with a number worth memorizing. If blood pressure can be measured at home, the threshold that changes what to do next is 180 systolic over 110 diastolic. A reading at or above that level is not a prompt to adjust medication. It is a prompt to call emergency services. That combination, a recent transient ischemic attack plus a hypertensive crisis, fits the clinical picture of imminent stroke risk, and standard guidelines treat it as an emergency re-entry line, not a situation to monitor from the sofa. Before discharge from any evaluation following a suspected TA, 3 questions are worth asking directly and by name. Has a carotid duplex ultrasound been performed or scheduled? Has a 24-hour cardiac monitor been ordered to screen for atrial fibrillation? Has a glycated hemoglobin test been drawn to assess average blood sugar over the past 3 months? If the answer to any of those is no, ask why not confrontationally, specifically. Each test looks at a different potential mechanism for what just happened, and leaving any one of them unplanned means leaving a possible cause unidentified. If the answer you receive is that everything looks fine and no follow-up has been arranged, that is the moment to push back. Everything looks fine means the acute neurological exam was normal at the time of evaluation. It does not mean the carotid artery is unobstructed. It does not mean atrial fibrillation was absent this morning and will be absent tonight. It does not mean blood sugar has not been quietly injuring the arterial lining for the past 3 years. It means one snapshot on one day showed nothing immediately obvious. That is a starting point. It is not clearance. The 3 tests that matter most after a transient ischemic attack are not interchangeable. Each one looks at a different piece of the same mechanism, and missing any one of them means leaving a potential cause unidentified and unaddressed. Most people, when told that follow-up tests have been arranged, assume the important ones are covered. Here is what the records show. The 3 tests most likely to identify the correctable cause of a TIA are also the 3 most likely to be omitted from a standard emergency discharge. Understanding what each one actually measures and why a simpler version of the same test would miss the point entirely is what gives you the standing to ask for them by name. The first is a carotid duplex ultrasound. You would probably assume any ultrasound of the neck covers what needs to be covered. That assumption is the gap. A standard ultrasound produces a structural image of the artery wall. It shows the shape of the vessel and the visible bulk of any plaque that has accumulated on the inner surface. surface. What it cannot show is whether blood is still moving through the narrowed segment adequately. A duplex ultrasound combines that structural picture with a real-time map of blood flow, including whether flow becomes turbulent and accelerated at a narrowed point. When a plaque has reduced the interior of a carotid artery significantly, blood does not slow down uniformly. It accelerates through the tight segment and becomes chaotic, the way water speeds up and churns when a river narrows suddenly. That turbulence has a measurable signature, and the flow velocity at the narrowed segment tells the examining physician how severe the obstruction actually is. The threshold that changes clinical decisions is a narrowing of roughly 70% or more. Doctors call that hemodynamically significant stenosis, meaning the narrowing is severe enough to meaningfully impair blood flow under normal conditions. Below that threshold, blood can still move through under adequate pressure. Above it, the question is no longer whether a stroke could occur. It is under what conditions the remaining flow would stop entirely. A small clot lodging at the already tight segment, a nighttime drop in blood pressure, a brief cardiac arrhythmia reducing output for a few seconds. Any of those in a vessel narrowed beyond 70% can be enough to complete the blockage. When stenosis reaches that level, surgeons may recommend a procedure called carotid endarterectomy, opening the artery and removing the plaque directly. In modern practice, it is a routine operation that prevents tens of thousands of strokes every year. The conversation about whether it is appropriate in a specific case cannot begin without the duplex ultrasound. A structural image alone will not start that conversation. The second test is a glycated hemoglobin measurement, written as HbA1c. Standard fasting glucose tests show what blood sugar is doing on one particular morning. You would probably assume that a normal fasting result means blood sugar is not a factor. Here is why that assumption misses the point. HbA1c shows what blood sugar has been doing for the past 3 months. Hemoglobin, the oxygen-carrying protein inside red blood cells, gradually accumulates sugar molecules over the lifespan of those cells, roughly 90 days. The higher blood sugar has been running over that period, the more of the hemoglobin becomes glycated. That 3-month average is already written into the blood before you arrive at the clinic, and a single fasting result the morning of the blood draw cannot alter it. The cutoffs are specific. An HbA1c below 5.7% is normal. Between 5.7 and 6.4% is the pre-diabetes range. At 6.5% or above, the picture fits diabetes. The pre-diabetes range is where this test earns its particular importance in stroke risk assessment. That gray zone, blood sugar elevated enough to cause damage, not yet elevated enough to carry a formal diagnosis, is sufficient to injure the endothelium silently for years. The endothelium is the microscopically thin layer of cells coating the inside of every artery, functioning like a smooth, non-stick surface that keeps blood components from clinging to the vessel wall. When endothelial cells are starved of adequate glucose delivery, they lose their shape, detach from the wall, and leave behind rough, scarred patches. Those patches are where cholesterol, platelets, and inflammatory proteins begin to accumulate. That is where plaques start, and that process is well underway before any fasting glucose test raises a flag. If this test has not been done recently or has never been done, it is a single blood draw, requires no fasting, and is especially important for anyone who has just experienced a TIA and carries any of the common background risk factors. The third test is a 24-hour Holter EKG. A standard electrocardiogram in a clinic lasts 10 to 20 seconds. You would probably assume that a normal clinic ECG means the heart rhythm is not a factor. Here is what that assumption costs. For a patient whose dangerous arrhythmia occurs twice a day for 30 seconds each time, a 10-second snapshot has a roughly 1 in 1,400 chance of capturing it. Holter monitoring records every heartbeat continuously for a full day while the patient goes about their normal routine, wearing a small device clipped to clothing or worn on the body. The arrhythmia it is specifically designed to catch is atrial fibrillation, a condition in which the upper chambers of the heart stop contracting in a coordinated rhythm and begin quivering chaotically. rapidly, sometimes at rates approaching 300 to 400 contractions per minute. Blood does not empty smoothly from the atria. It churns and pools. In that stagnant, churning blood, clots form easily. Those clots can leave the heart, travel through the carotid arteries, and lodge in a brain artery. Doctors call this a cardioembolic stroke, and it tends to be among the most severe. Many people with atrial fibrillation have no dramatic symptoms. At most, they notice occasional skipped beats, brief flutters, or a vague unease they attribute to caffeine or stress. A 10-second clinic ECG taken on a day when the rhythm happens to be normal returns a normal result. The arrhythmia is never identified. The clot risk is never addressed. If Holter monitoring catches atrial fibrillation, there are well-studied anticoagulant medications that, when prescribed and monitored correctly, reduce stroke risk in this condition by roughly 60 to 70%. That is not a marginal benefit. That is a documented, reproducible reduction in the probability of a specific and often catastrophic event, available only if the arrhythmia is first found. One more thing about the 72-hour window that is worth stating plainly. It does not close cleanly at hour 72. The acute risk curve flattens after 3 days, but a missed or ignored transient ischemic attack still warrants full evaluation days or weeks later. The vessel damage that generated the event does not repair itself between Tuesday and Friday. The arrhythmia that produced a clot last week will produce another. The pre-diabetes that has been injuring the endothelium for 3 years is still doing so. The window for preventing the next stroke is not a brief emergency that expires and disappears. It is a sustained opportunity that becomes less urgent with time, and urgency, in this context, is a resource worth using before it fades. Long-term prevention is not a separate conversation from the 72-hour protocol. It begins inside that window and extends outward from there. Managing blood sugar in the pre-diabetes range is not a watching strategy. An HbA1c between 5.7 and 6.4% is not a category to monitor until it crosses into diagnosis. It is the intervention zone, the period during which dietary change, physical activity, and in some cases medication can slow or reverse endothelial damage before plaques become obstructive. Every month in that range without active management is a month of continued vessel injury that does not announce itself. Stopping smoking removes a constant chemical assault on the arterial lining. With every cigarette, toxic compounds cause direct inflammatory damage to the endothelium, while nicotine and carbon monoxide simultaneously thicken the blood and increase how readily platelets clump. The combination, a damaged vessel wall and sticky blood, is close to ideal conditions for an ischemic event. Research shows that ischemic stroke risk in former smokers falls by roughly a factor of 2 to 4 compared to active smokers with otherwise similar profiles. That reduction accumulates over time, but it begins from the day smoking stops. If Holter monitoring identifies atrial fibrillation, that finding opens a direct conversation with a cardiologist about anticoagulation, a conversation that should happen before discharge. If the arrhythmia is caught during the initial workup and should be actively sought if Holter monitoring is arranged as outpatient follow-up. Here is what to do after this video. If you recognized any part of what was described, a brief episode of vision loss in one eye, sudden one-sided numbness, a few seconds of slurred or blocked speech, an unexpected stagger on a flat surface, write it down in plain language before the memory softens. Include the time it happened, how long it lasted, which side of the body was involved, and whether speech was affected. Bring that written account to a doctor, not as background context, as the opening of a specific conversation. Ask directly whether a carotid duplex ultrasound, a glycated hemoglobin test, and a 24-hour Holter EKG are indicated in your case. Ask for them by name. Do not accept everything looks fine as a conclusion. Accept it only as a description of what one examination on one day showed. Then ask what the next step is. The window opened. The question is whether you used it.